Alright guys, I'm going to talk a little bit about thyroid neoplasms and then briefly about MEN1, MEN2A, and MEN2B. So we'll start up here. Some general information about thyroid neoplasms is that they present as distinct solitary nodules. If it's a hot nodule, it's less likely to be a thyroid neoplasm and more likely to be something like Graves'. So hot meaning that it secretes T3 and T4 and you get hyperthyroidism. So a cold nodule is more likely to be an adenoma and carcinoma. Some different types of thyroid neoplasms. First is an adenoma. So because this is an oma, it's benign. It's, like I mentioned, it's often a cold nodule. And it's follicular in histology, and we see no invasion of the fibrous capsule. Numbers 2, 3, 4, and 5 are carcinoma. So the first type is papillary. This is the most common. It represents about 80% of all thyroid carcinomas. It presents with on histology, there's orphan antinuclei, which means that there's central clearing within the nuclei. So you sort of have the dark part of the nucleus on the outside and then a white part in the middle, so it looks like an eyeball. And you can also see psammoma bodies. So remember that psammoma bodies are dystrophic calcifications. I drew some pictures of kind of a little calcified whorl up above it. And I capitalized the P, S, and both M's to represent the four different types of cancers that we often see psammoma bodies in. So the P is for papillary thyroid cancer, which is what we're talking about now. The S is for serous cystadenocarcinoma, which is a surface epithelial tumor in the ovary. And then the two M's are for mesothelioma and meningioma. So that's one easy way of remembering that, P, S, M, M. Okay, number 3 is follicular. On histology, what you see here is a neoplasm that looks like an adenoma, but you have disruption of the fibrous capsule. So notice that I've written in red that an FNA is not enough for this diagnosis because the fine needle aspiration doesn't actually let us look at the capsule architecture. It just looks at the cells. So so a fine needle aspiration is not enough to make the diagnosis of a follicular carcinoma. And also, one important thing about this is that it spreads hematogenously. And we know that most carcinomas spread lymphatically, so this is an exception to that. Number 4 is medullary thyroid carcinoma. This is a neoplastic proliferation of the parafollicular C cells. So we can remember it's not a follicular neoplasm because it's a proliferation of the cells that are next to the follicles, the parafollicular cells. These cells secrete calcitonin, so we would see increased calcitonin and a compensatory or in a corresponding decrease in calcium. And this calcitonin can actually deposit in the form of amyloid. So what you see is malignant cells within an amyloid stroma. So that's an easy way to remember that you see this amyloid stroma is that it's actually the calcitonin that's depositing that forms the amyloid. And this is associated with MEN2, which we're going to talk about in a second. Lastly is anaplastic thyroid carcinoma. Not a lot we need to know. It's undifferentiated, as the name suggests. It's often seen in the elderly. And it has a poor prognosis, so it often invades surrounding tissues, which can cause it to present with a symptom like dysphagia. The treatment is thyroidectomy. There are some notable complications to this surgery. The first is recurrent laryngeal nerve damage. This often presents as hoarseness, and one way that I like to remember the muscles that are innervated by the recurrent laryngeal nerve is that it innervates the larynx and then any muscles that have the word arytenoid in it. So for example, the posterior cricoarytenoid muscle, the lateral cricoarytenoid muscle, the arytenoid muscle, the thyroarytenoid muscle, and then the ara epiglottis. Those are all innervated by the recurrent laryngeal nerve. Second complication is if you accidentally remove a piece of one of the parathyroid glands, you can get hypocalcemia. And lastly, if there's injury to the superior laryngeal nerve, which often happens when you ligate the superior thyroid artery, I believe, then you can have you can have damage to, or you can have a paralysis of the cricothyroid muscle. Notice how cricothyroid muscle doesn't have the word arytenoid in it, so we know it's not innervated by the recurrent laryngeal nerve. Okay, so moving on to men, we said that medullary carcinoma of the thyroid is associated with MEN2. So let's talk a little about that. The easiest way, I think, to remember this is to first write out PPP, MPM, okay? And then once you've done that, you can circle these top 3 Ps, which are the 3 Ps that are most superior in the body, so the pituitary, pancreas, and the parathyroids. And then you can circle these bottom 3, so medullary carcinoma, pheochromocytoma, and mucosal neuromas. So that's MEN1 and MEN2B. And then MEN2A is just whatever's in between. And you can remember that it starts and stops at these 2 Ps that represent organs that we have 2 of. So, or neoplasms of those organs. So you can have a parathyroid neoplasm or a pheochromocytoma. Let's see. The reason that these are both considered MEN2 is because they have the same genetic etiology. So it's a mutation in the RET oncogene, and MEN1 is a mutation in the MEN1 gene. So that's easy to remember. Okay, hope that was helpful.